So did you know, at what point did you decide you were going to be a surgeon? What was the
From the first day I decided to be the doctor.
Really? And that was okay. And what attracted you? What was the attraction?
Well, I think this is the best way to know, to help people. Like, just you do something and it's right away,
Immediate
immediate
gratification.
to have a result and immediate satisfaction or whatever
Yeah.
you can call it.
So your training was all in Israel?
The training is
Yeah.
yes.
Yeah. And
I did all the residency here in Jerusalem in the Hadassah Medical Center.
that's okay. It's wonderful.
And then I left. I decided to be to devote myself to trauma care. And it was not easy way, but still, I'm not.
And
And I left to United States for fellowship
where did you do your fellowship?
in Baltimore.
Oh, shock trauma. Okay, it's again world renowned. So you can add America to Hungary, Russia,
Right.
And Belarus, and Israel. How long did you spend at shock trauma?
2 years.
And then came back.
Yes, I came back and I actually started career as a general surgery, and then I got the position of the director of trauma service, and now we added to that the emergency surgery, acute care surgery, it's called like that, and we built the service under the division of general surgery.
So when I trained in the UK and then moved to the United States, a surgeon did everything. You
Right.
did. You might have a specialty interest, but if a trauma came in, a gunshot wound, knife, motor vehicle accident, or a perforated diverticulitis, you would do those things as well.
Right.
In any form of surgery, specialization needs to improve skills. What would you say it is about combining emergency surgery and trauma surgery that's appealing to you and that makes sense?
The trauma surgery became very much non-operative because of different technologies, and we understand more about the trauma issues, and so it's a lot of intensive care work. It's a lot of angiography and stuff like that. That it's not handy. And then the emergency cases are very similar to trauma people in terms of physiology. So it's a different mindset. I think about physiology first, and then think about how to get patient better, and then how to treat his anatomy. So it's like backward from the elective surgery, like colorectal, for example. You have your disease, you know how to take it out, and that's it.
Mm-hmm. That makes sense. Additionally, there's a big move in surgery at the moment for enhanced recovery, right? ERAS. You don't have that luxury.
Unfortunately.
Yeah, because you're dealing with people who are acutely ill. But you can implement some of the changes, like maintenance of body temperature. What are your thoughts, given your specialty, about ERAS and how it plays into elective cases, and what elements can you bring to bear, given that you don't have preoperative preparation?
I think it's a lot about the quality of care. You have to handle some kind of quality, even those patients are sick and severely ill. But the ERAS actually help to maintain the flow of the things in the right decision. So technically you do something that is not quite planned, but then you come to the point when you can actually switch to the enhancement. You just do whatever you have to do for the patient that is doing better, actually. Start from prevention and then if we have more quality assessment, it would be probably better.
So personal audit is also a key component.
Yes.
Monitoring your own successes
Right.
and your morbidity, which
think-
is an inevitable part of
Yes,
this. Looking
it's
after
not enough, implemented, at least here in Israel.
Yeah.
So I learned that being in the United States. Here we try to maintain some registry and move toward the care that is built under the sort of guidelines. So we spend a lot of time putting together some guidelines with the people abroad. There's a World Society for Emergency Surgery, and I'm very active in that. So we do publish a lot of guidelines for acute diseases that's related to surgery, and we try to make it happen.
So you mentioned the non-operative management of trauma, and again reflecting on my own life in surgery. For instance, looking after patients with ruptured spleen. When I was training, you ligate the splenic artery and vein, and you take the spleen out and hope that you won't have splenosis, right? That would be one example of non-invasive management today, or less invasive management. Can you tell me some of the others that you see make an impact, moving away from operative to less invasive?
I think most of the liver trauma today is managed non-invasively. So very few cases that we did operate through the years. Even penetrating injury to the liver and so far, so we have a lot of experience doing things non-operatively. It's, we just feel that it's better for patients. Sometimes you want to operate because it's what you like to do, but it's
Not
better
in the
for the patient
patient,
to keep your hands in your pocket than to open an abdomen and packed and feel that it may cause complications, more complications than
Yes.
you are not doing. So it's
So really the team approach for the management of trauma is critical. Interventional radiologists, critical care, respiratory physicians, I imagine. Who are the key team members for you? And do you, presumably you have regular conferences in your hospital to, like tumor board, basically evaluate the care of trauma patients?
we have trauma meetings every month, and we have a National Trauma Society, that I'm actually the chairman of the society in Israel.
Busy
this year.
chap.
So I have a lot of responsibility for that as well. So it's all about teaching most often. And what was the question?
Well, team members.
Team
members for the care of the trauma patient. Who constitutes your core team?
In whole Israel and also in Hadassah, the general surgical department under trauma. We are in charge of all trauma patients, and then we try to cooperate with, we're cooperating with the orthopedics, with neuro, with the ICU people. That's a lot of, every department in the hospital should be involved when there's a case that fits their specialty.
Right.
And when we talk, for example, for tomorrow, I will talk a bit about the major trauma and what to do about the rectal injuries and things like that, but we are very much involved, our colorectal surgeons, to help my team with the decision making and some think that they are better than me in doing surgical approach to certain things.
So I was talking with Professor Abe Fingerhut the other day about surgical ego and how we need to keep our ego out of the operating room and make the decisions. And he's a very experienced, wise gentleman. And I think for people who are not trauma surgeons or don't see trauma, general public, their image of what the emergency room is like. It's very different to the reality. It should be a very calm, well-drilled team. Is that's your experience?
That's what my experience is. So we work we're not trying not to be so loud and to respect others. But the people actually know when the bed trauma case arrives, so they know who is in charge. So that makes things much easier because nobody's trying to be too much hands-on before the decision being done by me or my partner who is another trauma surgeon in our service.
So tell me a little bit about the mix of trauma that you see in Israel. Everyone is aware of, the sadness that in our world we have to deal with terrorist incidents, but presumably there's the usual motor vehicle accidents and assaults. But are there any special kinds of injuries you see as a result of terrorist activities, for instance, blast injuries and such like?
It's actually 20 years we more or less not in a mode of mass casualties anymore. So in the year 2000, 2004, it was a bad days. Seriously, it was 5 years of everyday hard work, and we had terror attacks twice in a week. In Jerusalem only, I'm not talking about all Israel, but at least in Jerusalem. It was a good experience for the surgeon, but bad experience generally. And then it went down slowly, and now we have very few so-called lone wolves attacks. So some people, they got managed by any idea, and it's for example, like a month ago, we have a ramming attack of somebody who take his private car and get into the crowd, often to target the soldiers or other security personnel. So it's also caused damage, and the people are very badly injured, but it's a different type of injuries.
Yes.
It's not blast anymore, it's not gunshots, few of those. Also stabbing still exists here in the old city, happens once in a while.
Yes. Yeah. Well, I'm sure everyone in Israel is very grateful to have such a well-trained and thoughtful surgeon involved in casualty in looking after these patients. But I'm sure equally that you would love to not be very busy at all.
Yes.
For those days to hopefully come in the near future.
Yeah, we still on a daily basis we deal with the falls, and
yes.
People got older, so the trauma, I'm not saying it's all geriatrics, but a lot.
Yes.
So sick people, old people have small impact, low energy trauma, but they got very quickly sick, and then intensive care got much better than it was 20 years ago. So we do have still job in trauma.
You're not going to be out of work anytime soon.
That's why actually emergency surgery comes to help us do more stuff. Because once more, I'd like to have my case in operating theater,
yes.
Not only in the emergency department.
Absolutely. Absolutely. So you're participating at the meeting here in Jerusalem, which is a joint effort between the Cleveland Clinic David Jagerman Memorial course and the Israeli Colorectal Society. I've already mentioned that you collaborate with the colorectal surgeons in terms of evaluating rectal injuries and then helping you treat them. And again, commendable, because you only get one chance to get things right. The first time is always the best. Tell me, have you had a chance to spend any time at the meeting yet and hear any of the talks?
Very few.
Okay. Is there anything in particular that you've got your eye on in the program that you want to hear?
Yeah, there is a lot of things that are very important for, some things are interesting for me personally about some emergency cases also discussed here, and some new technologies that we may implement or not in our daily, surgical work. Also doing elective surgery as any other surgeon is doing, so it's also important to be up to date.
Well, I hope you have a chance to hear. I've certainly learnt a lot. There's some great speakers here. Thank you very much for spending a little bit of time with us. And I haven't been to the Hadassah for many years. We were talking about Ariel. But when I came many years ago, I visited Hadassah, and they actually had a fundraising event in New York a number of years ago, and they did a wonderful presentation on the work there. It's an amazing institution, one of the best hospitals in the world.
Well,
Yeah.
it still sounds like that.
It is.
We try to make it happen still.
Well, it's very refreshing talking.